Welcome, everyone. It's on now. I know folks are filtering in and whatnot. Grab your lunch, eat. This is going to be low-key. Welcome to our Lunch and Learn. We're hoping this is going to be much more of kind of a workshop-oriented thing, less didactic, more interactive. So we're glad that everyone's here. Our disclaimer, we are Abe Sender and Chandra Gordon, and we do not have significant disclosures. For today's session, we're going to start out with some just welcome, session overview, ground rules, and then get into some introductions, break into some individual activities, come back together for a little short didactic, and then we'll have a group activity that will take most of our time together. You have some paperwork in front of you. If folks didn't get the handouts when they came in, I would invite you to head over to the 323 door and grab the handouts. We'll be using those later. And then we'll end with some wrap up and takeaways. So our objectives today, we want to recognize how clinical documentation can perpetuate stereotypes and shape the attitudes, decisions, and behaviors of future care providers. We want to apply best practices for writing clinical notes that are accurate, respectful, and center the humanity of each of our patients. And we want to promote a culture of accountability and critical awareness in team communication to reduce harm and advance equity in care. And while we won't be addressing it specifically, we want to keep in mind that the changing political landscape is having a very significant impact on words, the words we're allowed to use, the words we choose, etc. So these are just some group agreements we wanted to put up there. We ask everyone to speak for themselves and also honor the experience of others. We want to remember confidentiality. What's said in this room stays in this room. We do ask for everyone's engaged attention. We understand there may be interruptions, etc. If you could just kind of quietly take those outside of the room, that would be appreciated. And then just remember everyone has something to add. If you're like me and you talk a lot, remember kind of others. And if you're someone who is hesitant to speak, we really want to encourage your participation. We really want folks to try and lean into that discomfort today. So.
Again, welcome everyone. It is great to see all these people at this Lunch and Learn. You just don't know how exciting we are to be able to have such a large, robust group this afternoon. Well, we're going to do introductions today, but we're going to do introductions a little bit differently. And that instead of introducing ourselves individually, we're going to take time to actually introduce each other, but in a more meaningful way that really aligns with our workshop today. So I'm not texting, I'm getting my notes off my phone. So with that, I have the pleasure of introducing Abe Sender. He is a physician assistant at the University of Vermont Adult CF Center, engaged in community outreach, clinical research, and professional education. But what this introduction doesn't capture is who he truly is. He is a devoted father of two, a proud member of the LGBTQ plus community, someone whose faith and compassion shows up in how he treats people, not just patients. He's the kind of colleague who brings calm into chaos and who reminds us that equity isn't just theory, it's relationship. And I'll turn it over to Abe.
Thank you, Chandra. I bring chaos sometimes too. So, full disclosure, this great idea came from Chandra about an hour ago. So my intro is not quite as prepared. It's a little rougher. But this is my dear friend and colleague, Chandra Gordon. She's a pediatric social worker at the University of Kansas Health System in Kansas City, where the worst football team plays. She works diligently in the clinical realm, but also on health advocacy and policy. Her areas of focus include health equity and advocacy for traditionally underrepresented groups. She is a Black woman who lives in the community in which she was born and raised and travels between communities from her neighborhood into the healthcare community each and every day, constantly code switching between these environments. Her passion is building bridges between these communities and advocating and giving voice to those folks who are less comfortable within healthcare and medical environments.
All right. So, thank you, Abe. And the Chiefs are still the best. All right. So, what we want to do, come on in. There's a lot of seats up front. Just fill in. We feel like this workshop is not one of those that is very technical. So, we wanted to feel like we're a community and that everyone could connect. So, don't feel intimidated about being up front. All right, so we do have some instructions on how we're going to do introductions, but the room setup is a little bit different. So please, we're going to modify what the instructions say on our slide. So what we're going to ask you to do is find someone, a neighbor, and we want you to do at this time, just share your name, your role, and your connection to CF, and a fun fact about yourself. So if it's someone right next to you, or if you're not sitting directly next to someone, please find someone to introduce yourself to. And so we'll give you a couple of minutes to do that. So again, your name, what your role or your connection is in CF, and a fun fact about yourself. All right. So we're gonna try to come back together, and I hope everyone got a chance to at least learn the name of the person that they're sitting next to, and hopefully actually learned a little bit about their role and where they're from. So did everybody get to introduce themselves? Because I don't want to make everybody know. Okay. We want to make sure that happens. All right. Now we're going to take this just a little bit deeper. And we're going to ask you to really take some time to really kind of engage in this conversation with us. And what we're going to start this activity, we'll start our session off, is really engaging in an activity where we call it seeing ourselves in each other. So I'm going to read a series of statements. I don't like standing at the podium, so this is driving me crazy. I like to move. I don't like the stage always. I know. I'll do that next time. All right. So what I want to do is I'm going to read a series of statements. And as I read the statements, what I'm going to ask you to do is really just take some time, just take a moment. And I want you to, again, this is an activity where we're not going to use words. We're just going to actually just acknowledge by gesture. So I'm going to read a series of statements. And if one applies to you, you can simply raise your hand or put your hand over your heart if it applies to you. All right. So you're going to either raise your hand or put your hand over your heart if the statement applies to you. Again, no words, just actually sitting in the moment of hearing these statements read. And then also take a time to glance around the room as we're doing the activity. All right. So raise your hand or place your hand over your heart if someone's actions or words have ever made a positive difference in your life. Raise your hand or place your hand over your heart if you've ever cared for someone whose needs were not easily understood by others. Raise your hand or place your hand over your heart if you've ever been misunderstood because of how someone described you. Raise your hand or place your hand over your heart if your story cannot be captured by a single word or a label. Raise your hand or place your hand over your heart if you've ever been denied an opportunity because of your identity, condition, or circumstance. Raise your hand or place your hand over your heart if you've ever struggled to get the resources you needed. Now, as we're sitting in this time of just really sitting and reflecting on the lived experience, I hope you had a chance to kind of glance around and be able to see the diversity of the lived experience in the room. But I want us to take it a little bit deeper, and I want you to think about who is in your circle. So everyone should have picked up a blank piece of paper. I want you to put your name in the center of the blank piece of paper and put a circle around your name. So does everyone have a blank? Okay.
Anyone need?
Anyone need? Okay. All right. So what you're going to do, as I said, you're going to take that blank sheet of paper. I want you to put your name in the middle with a circle around it. As statements are read, think about the people in your life: family, friends, neighbors, co-workers, loved ones, etc. If a statement applies to someone you know, write down their name on your paper and circle it. Now, please note names separately, and feel free to note the same person multiple times if that statement applies. So again, we're going to put our name in the middle with a circle around it. There's going to be a series of statements that will be read. If any of those statements applies to anyone that you have a personal connection to, family, friends, neighbor, coworker, loved one, we want you to write their name on that paper somewhere around your name and also put a circle around it. And again, you're going to note, names can be noted multiple times if the statement applies, but we want you to individually write it each time, okay? So who's in your circle? Is anyone in your circle whose resilience has inspired you? Who's in your circle? Is there someone whose story has been misunderstood or misrepresented by others? Who's in your circle? Is it someone you know who speaks more than one language? Who's in your circle? Someone you know who has been labeled instead of understood? Who's in your circle? Is it someone you know who has an visible or invisible disability? Who's in your circle? Is it someone you know who's had difficulty obtaining medication or accessing health care? Who's in your circle? Is it someone you know who has found creative ways to overcome a challenge? Who's in your circle? Could it be someone you know who's experienced housing instability or homelessness? Who's in your circle? Someone whose life has been impacted due to being a caregiver? Who's in your circle? Could it be someone who has faced discrimination based on race, sexual orientation, gender, ability, religion, nationality? Who's in your circle? Could it be someone you know who has faced challenges with substance use? And the final question is, who's in your circle? Is it someone who struggled with housing, food, or basic needs? If we look at our paper, you may have noticed how quickly those circles fill. And what it represents is that the diversity of life is not distant, it's close. Equity is not about those people, it's about our people. Every name you've written represents a story, and often those stories are carried into healthcare, education, and systems through the words we use. The way we write, describe, and document others can either honor their humanity or diminish it. Equity in writing begins with seeing the fullness of people's lives. So when we think about their lives, their struggles, their strengths, we can now imagine how that might appear in a medical record. What words would honor them? What words will reduce them to a label? Every word we choose has its power. It can humanize or it can harm. It can open doors or it can close them. When we write, we're writing about someone's circle, someone's loved one. And we have to realize that the dignity of our words do matter. So as we begin to go into this session, I want to just leave you, we're going to pause for a minute, not leave you. Pause for a minute on this particular quote by a Danish theologian. And he said, once you label me, you negate me. So we want you just, as we begin to dive deeper into this topic, just realizing the power of the words and the impact that they could have. And I'll turn it over to Abe.
Thank you, Chandra. So I wanted to take a minute to follow up on the last two activities that Chandra ran us through. Thinking about perception, a definition of perception that I think is most relevant to kind of what we're doing here today is to consider a way of regarding, understanding, or interpreting something, a mental impression. As I consider these activities, something that comes up for me is the way our brains are hardwired to make snap decisions and judgments as a matter of survival. However, each piece of new information that we obtain changes the way we think about things. This image demonstrates how we often see ourselves as separate, as individuals, different from others, particularly new people. But we're often able to very quickly find connection with folks through storytelling and learning about each other. It's our hope today that folks in this room will be able to find connections and commonalities with others that they didn't recognize previously when they walked in. So now let's think about this concept and how it applies in the clinical setting. One way we share and obtain information about our patients is through reading and writing in the electronic medical record. Clinical documentation, referral letters, secure messaging, etc. And within these medical settings, this is their primary source of information about individual humans. And in many cases, we scour the medical record to learn about folks and form these judgments before we ever even meet them. And this is really important preparation for a clinical encounter, but it also predisposes us to forming ideas and perceptions that can ultimately stick with our patients, regardless of the validity or truth to the statement. So, if anyone's ever seen me in PEP, this is my favorite slide. I like to incorporate it in everything, but I do think this is an image we borrowed from Press Ganey, and I think it does a really good job of helping explain the suffering associated with chronic disease. More importantly, it helps us distinguish between what's inherent to the disease and what's avoidable, and where we can therefore make a change and have an impact. So when we look at this, we see the center of the image is the patient. And surrounded by this is this first orange circle labeled inherent suffering associated with the diagnosis. This is the existential stuff. And then the next circle, the dark blue circle, is the inherent suffering associated with the treatment. And I think in the CF space, we have a particularly interesting window into this. I think we must prescribe more treatment time than any other disease space. I'd love to be proven wrong. That's a big statement, but I think it's unique in the CF space. The last ring there, the lighter blue, is the avoidable suffering associated with miscommunication, lack of empathy, lack of patient engagement, wait time. And this is sort of where our words and our word choice have a big impact. So when we think about the words we choose, we can reduce suffering by using intentional positive communication, by building trust and empathy, building relationships, and reducing miscommunication. Whereas our kind of negative communication can increase suffering by introducing bias, reinforcing stereotypes and stigma, reducing self-esteem, inciting shame, and can lead to harm. So we don't have our notes up here, sorry. So writing can impact a person's self-perception by building or reducing self-esteem, and even impact when or if they will contact us in the future. Right? Our words can affect someone's comfort. It can create discomfort. It can create judgment, shame, feelings of inadequacy that can impact people's healthcare decisions for a long time to come. Whether or not they're going to come to clinic, whether or not they're going to call us when they need help, whether or not they're going to enroll in a clinical research study. Clinically, our writing tells a story about a person and can introduce bias, particularly depending upon the choice of words we use. In clinical research in particular, if we don't do a good job in our writing and our documentation, say in a consent or an advertisement for a study, etc., it can cause people to self-select out of research, out of participation, and this self-selection can impact our clinical conclusions that we draw from the research. And it can affect the broader applicability of the conclusions we draw. Who does this pertain to? What groups does this information potentially not pertain to? So things we want you to consider in your writing. So think about the purpose. Why are we including this statement? What's the best word choice we can use here? Think about impact. How could including this piece of information, these words, affect the person? Will including it make any clinical difference or change in the care plan? What's the benefit? And then the outcome. What possible downstream effects could occur? What health outcomes or goals could be changed? How could this affect insurance, safety, disability, etc.? So we're going to walk through a brief example together to see how small language choices can make a big difference. During this demonstration, we're going to look at how these word choices shape our perceptions. The way that we describe someone influences how readers see them. We're going to look at how to recognize and reframe biased or judgmental language and identify what feels loaded or stigmatizing. And we're going to look at how to rewrite using intentional person-centered language, centering humanity and context, strengths in the clinical and professional writing that we complete. So we're going to look at this clinical scenario, and we're going to run through. You guys have in front of you the colored sheet, the sheet with printed in color. So I invite you to look at that. Don't get lost in the words as we talk here. And Chandra, could you read this for us?
Okay. Tanya is a 43-year-old woman with CF, pancreatic insufficiency, and CFRD complicated by a long history of drug abuse, who presents to CF Clinic for interval follow-up. She was last seen in clinic over 1 year ago, but opted to return today so we could continue to prescribe her ETI. Over the past year, she has not had consistent housing and has been couch surfing as such, she has not been consistent with treatments, but tries to at least take her ETI.
All right. So the first thing we're going to do is sort of identify statements. So on the back of that piece of paper, you'll see we've got a grid laid out where we're going to ask folks to look for words or phrases that stand out as maybe judgmental or loaded or incomplete. And that will sort of be step one. So just walking through this as an example, does anybody have examples from this that they feel like fits the bill?
And you guys can call it out, Don't feel the need to have to go to the mic.
Drug abuse. Long history of drug abuse. Great. What else? Couch surfing. Yes. What else? Oh, but. Yes. Correct. Any others? What else? Non-adherence. Great. Coming just to get her refills. At least. Great. Awesome. So all of these phrases are small, right? But they carry a lot of weight. So each one shapes how the care team might see Tanya even before they go in. You know, I don't know. There's always new faces at the conference every year, right? If we haven't seen her in a year, there's almost guaranteed to be new members of the team who are going to be reading this and have never met her. So thinking about that, let's use this equity and writing worksheet you have in front of you to run through run through the whole process for one of these statements, right? So first one you guys came up with was long history of drug abuse. So thinking about that, what's folks' reaction to this language?
How long is long?
Okay, great.
Judgment.
It's judgmental. It's not clear. It doesn't tell us how long. Is it current, right? Is it criminal? Feels harsh. It's defining this person simply by their substance abuse, not kind of every other facet of their humanity. So how could this language affect someone's care? Drug seeking, great. What else? Great. It doesn't help us understand them as a human. It just puts them as absolutely. Yeah, right. Right. Why should we? Absolutely. She said it doesn't explore what's going on in her life. So it might bias the care team. It might lower their trust in her. Why might this language have been used? What was the point of including it in the statement? Yeah, so she said substance abuse may have impacts on clinical decision making, right? Like medication choice, et cetera. And she said hopefully it wasn't added with any malicious intent, which is, I think, a huge part of what we're talking about today. So thank you for that. It's a quick way to summarize risk, right? There's risk associated with drug use, of course. So what's our recommendation? Should we keep it? Should we eliminate it? Should we rephrase it? Great. And how should we rephrase it? Maybe. Great. So rephrasing it is going to kind of provide us the facts, but in a much more respectful way. So we're going to rewrite it, and we want to focus on key elements of person-first language, using context instead of blame, and trying to focus on her strengths and her efforts. So, Chandra, could you read this rewritten paragraph?
Yes. Tanya is a 43-year-old woman living with CF, pancreatic insufficiency, and CF-related diabetes. She returns to clinic today for cystic fibrosis care. Her first visit was a year ago. During this time, she experienced housing instability, which made medical appointments and treatment routines challenging. She is currently living with friends and has continued to prioritize taking her ETI. She welcomes support and strategies that can help her sustain both her health and housing needs.
Thank you. So now we're going to switch to a group activity, and in full disclosure, we were sort of picturing round tables. But you are all very capable and you can help us out here. So you've got the worksheet and the list of scenarios. What we're going to ask folks to do, we're going to run through the worksheet as a group, kind of as groups twice. And we'll have you switch your groups around somewhere in the middle, and we'll be in charge of letting you know when that'll be. I want you to find, when I say go, I want you to find groups of kind of like maybe 3 to 5, 4-ish people, and then agree on a scenario. So you also have a list of clinical scenarios with you. And then everybody take some time to kind of quietly read that scenario and identify some of the statements that you think might be ripe for changing or eliminating. And then work as a group to try and go through the worksheet step by step. So you know, looking at the what's your reaction impact, like the impact, how could this language affect care, why did we use it, and should we keep it or eliminate it or rephrase it. And then have conversations and fill it out as a group, and then we'll have you switch, and at the end of 2 rounds we'll debrief.
I will just add, you don't have to rewrite it just for time's sake. Just we want to make sure you're at least having a discussion about what that might look like, but you don't have to officially rewrite it on the worksheet.
Great, thanks. So find your groups. I know.
Right? All right. We have enjoyed seeing all of the dialogue and discussion. I know you probably have not finished or shared everything that you might have wanted to share, but we want to take some time to kind of come back together and debrief this activity. We will have a chance to do another one. So just know we're still going to be able to have a deeper dive. But we want to just take some time to just get an overall summary of kind of what this experience has been like, or what did you find as you were working in the group. And since we have a large group, we're just going to do this kind of, we've been trying to figure out logistics because it changed up our plan based on room configuration, but we always have to work through uncertainties, right? So we're going to start on this side of the room. Is there any particular group that will want to share with us? One, just read your scenario. And then for the group, just kind of walk us through what your group came up with as regards to the questions that are on the screen. Is there any one particular group that would like to share out? Don't be shy. Do you guys want me to start on this side? They say yes. Anybody on this side? Start on that side. Well, any group. All right, we'll make it fair. Is there any group that would want to share out? All right, we got a group over here. Thank you.
You're our favorite person.
Okay. So we want scenario number 3.
Okay.
And you want us to read it first?
Yes, just because
Okay.
we all worked on different scenarios potentially.
James is a 17-year-old black, intellectually disabled boy with a history of obesity, self-harm, and asthma who presents for evaluation of a 5-centimeter laceration to his left forearm. He's accompanied by his foster mother. Patient reports he sustained this injury when a window shut on him while he was helping his elderly neighbor install her AC unit. So as we went through this, the first thing we thought was, why does it need to say he's black? Because we don't really identify any other race or ethnic group consistently, but it does seem like black gets used a lot.
Okay.
We then kind of like parsed it down to what is the basic information that we need. And that is that he has a large laceration, that he's a minor, so we need that 17 years of age because we've got to worry about who's going to consent for treatment, right? We talked about, did we really need to say foster care? Could we just say legal guardian? Because being in foster care can definitely generate biases. We did find that there was a positive bias that we all kind of felt when we found out that he was helping his elderly neighbor. Right? But then we also really struggled with, do we need to know that he has a history of obesity or is currently obese? Do we need to know the history of self-harm, and do we need to know the history of asthma? And we were thinking that of those 3, we don't know that we needed to know all of that. Now, the one thing that we did kind of get caught up on is the self-harm. Because as we started thinking through the injury, if a window falls on you, unless it's got something sharp, how do you end up with a 5-centimeter laceration? And we don't want him to leave, I'm assuming emergency room, without getting all of the care he needs. Like, it would be really easy to just patch up the laceration and let him go back. But with his history of self-harm, is there something we need to dig a little bit deeper, get to know him, make sure we're interviewing him by himself to see if there's something else going on, because we don't want him going back to a dangerous environment.
Thank you. All right. Okay.
Thank you. That was great.
There's the fact that he has an intellectual disability. So the whole, what am I saying, decision making and agency that comes into play, right? Also, there is not, what is it called, person-centered language when you say intellectually disabled versus has an intellectual disability. So yeah, that's what I was.
Thank you.
Thank you.
One more thing that we noticed is that in all the scenarios, they typically say male or female, and they specifically refer to him as a boy. So I think that is something that also needed to be noted. So.
Thank you. All right. Do we have another group that would like to share a different scenario?
Yeah.
Okay.
Great.
Thank you.
We're sharing responsibilities. Scenario 6. A 16-year-old Middle Eastern female with cystic fibrosis presents with worsening respiratory symptoms. Her family has a long history of declining certain medical interventions, citing religious beliefs and cultural practices. They have expressed skepticism about Western medicine and prefer to rely on traditional remedies and prayer. Providers note repeated refusals of recommended treatments, including IV antibiotics and lung transplant evaluation. The family is described in the chart as difficult to engage, non-adherent, and resistant to medical advice. Despite multiple hospitalizations in the past year, they continue to prioritize faith-based approaches, raising concern about her long-term prognosis and ability to follow through with medical care.
All right, for impact, our initial reaction was most of this was just very rude, very blaming, finger pointing. We underlined almost the entire paragraph. For impact outcome, how could this language affect the individual's care? It really put a us versus them mentality of, like what they're doing wrong. It's not us, it's them. And so I think that for care, it's going to continue to go that way. We're not kind of meeting them in the middle. For purpose, why is this language being used? I really feel like it's trying to portray that picture of this patient is not doing well because of the family. And because of and blaming their religious and their faith. And it's really missing an opportunity to enhance collaboration with that family. We didn't hear anything about, there's certain things that they may not be able to do or willing to do, but what is it that they are able to do? And where can we compromise? Where can we meet them in the middle? How can we best support them? Are we talking about their culture and their faith? Are we bringing in any of their, if they want to bring one of their religious leaders to a meeting to kind of help explain things as well, let's allow that to happen. We're not really hearing them. We're just saying, well, because of your faith, you're not choosing to do this, so it's your fault. And I feel like this language really made it seem like this family didn't care about their 16-year-old child when they do, because they're continually coming to appointments. They're just not getting anything where it's a collaborative experience.
All right. Thank you. All right. So what we're going to do now is you're going to have another chance to do this activity. But this time around, we want you to take the opportunity to try to rewrite the scenario. So we had the practice of kind of going through, highlighting the words that we felt, or just kind of going it through based on our structure. But we want you to think about, how would you, as a group, present this clinical note in a more person-centered way? So we're going to give you that same time of working with your group, pick another scenario, or if you want to continue working on the scenario you did, it's totally up to you guys. We want to give you that flexibility. But we really want you to take a chance, take an opportunity to just sit with that information that is before you, and how could you, as a group, come up with a more person-centered message? Person-centered note that really speaks to the true humanity of that patient. All right, we good? Okay. All right, we're gonna come back together as a large group. As you guys are finishing up kind of your discussions, we will have time, definitely hoping that this will be time for us to continue the conversation, but as a large group. So what we wanna do now is we do want to ask one group from each section. We already have a lot of that already did at the beginning, but we do wanna hear, how did some of the groups rewrite these scenarios to really respect and honor the lived experience and really promote the humanity of us all? So could I get one group from this side? Let us know what your number was. You can read it out loud and then share with us how you rewrote it to be able to honor that person. Any group willing to share? So here's the thing, guys, we're all being nervous about it, right? But we read each other's words every day when we're sharing notes, right? Okay, we got a group. Thank you. All right, tell us your scenario number, and then that way we can follow along.
We did scenario 6, which happened to be one of the ones we talked about earlier. Oh, sorry. We did scenario 6.
Okay.
Yes. So we named our patient Sonia because we felt like it was not very person-centered to not have a name on this HPI. So we said Sonia is a 16-year-old female with a history of cystic fibrosis who presents today for worsening respiratory symptoms. In brackets here, we didn't actually write it out, but I would have liked to see like specific respiratory symptoms, how long they've been going on. There was like absolutely no information about her actual acute illness. So that is what would have been listed next, the next couple sentences. Then we said, due to her family's religion, and we would hope that they would list the specific religion to give us a little bit more information. They have chosen in the past to decline certain interventions, such as IV antibiotics and a lung transplant. Interventions they have been comfortable pursuing are blank, 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 and listing those. And then we said, and again, we kind of made up some stuff here, but we said Sonia consistently takes her Trikafta and attends her clinic visits. And then our last line here, of note, she has Of note, she has been hospitalized multiple times in the past year, which has raised concern for how to best treat her respiratory infections and cystic fibrosis while also honoring her religious beliefs.
All right. Thank you. All right.
Thank
Do we
you.
have a group from the middle? Okay. Thank you.
And again. Great.
So this is just another option for the same scenario that we came through. I like that you guys named her. You didn't pick a name, but I think that would be very important. So from this scenario, we have a 16-year-old woman living with cystic fibrosis, presenting with worsening respiratory symptoms. Treatments such as IV antibiotics and lung transplant have been discussed, however, not within her family and religious goals of care. Her prognosis is guarded with declining lung function. We will continue to provide supportive care and engage her and her family and the family's community leaders.
Thank you. All right, last section of the room. Do we have a group willing to share? Oh, thank you.
One of our other group members chose number 4 and then stepped out. So honestly, we barely have 2 sentences.
Read it.
Sure. Somebody did maybe do this. Okay. A 15-year-old black male with a diagnosis of cystic fibrosis, disruptive mood dysregulation disorder, and ADHD presents with a history of behavioral and emotional regulation challenges. He is 6'5" and weighs 331 pounds. He is currently in the custody of the Department for Children and Families and was recently removed from a group home due to physical violence. At admission, he was staying overnight at his mother's home and spending his days at the DCF office. His psychiatric history includes multiple hospitalizations and emergency department visits over the past 4 years. His presentation is described as recurrent aggression, impulsivity, and difficulty with emotion regulation, requiring a highly structured and supervised environment. Due to his size and history, interventions emphasize individualized crisis planning, therapeutic placement, psychiatric management, behavioral strategies such as applied behavioral analysis, and caregiver support. So we were like, what is he admitted for, and what is the purpose of it? Because if we're guessing, he doesn't have a name. We feel like the size is aggressive. We don't know what the goal is. So we're kind of grasping. We are struggling. Gabriel, we gave him a name. Gabriel is a 15-year-old male with reported diagnosis of CF, DMDD, and ADHD, who is currently admitted for individualized crisis planning, therapeutic placement, psychiatric management, behavioral strategies, and caregiver support. I don't know what the rest of the plan is, but we scratched out a lot because we don't know what the goal is. So we don't know what's relevant or not relevant, because if he is looking for inpatient placement, they do need to know that he also has CF, which would need managed. And for the staff, if he really is aggressive currently, then they would need to know that. But the rest of it, I'm like, I've never heard of a patient living at home with the mother and sleeping there and then just spending all day at the DFACS office. Like, that's not normal for me as somebody who used to work at the DFACS office. But we're just stuck. Welcome to recommendations, please, and thank you.
All right, thank you. Do we have any other group that's just dying to share a scenario? We want to make sure we honor that. All right. Oh, back there? Okay. Yes, we would love to hear.
I am really excited. Okay, we did scenario 7. Do I need to read the original?
Yes,
okay.
Please.
All right. Okay. So a 42-year-old Hispanic female with cystic fibrosis presents with worsening lung function and frequent pulmonary exacerbations. She reports difficulty affording her medications and airway clearance equipment and has several missed appointments. Sorry, I had crossed off stuff, so I'm like training appointments due to transportation barriers. She is unemployed, lives in a small apartment with her 3 children, and relies on public assistance. Providers describe her nutrition as, quote, poor, noting frequent fast food consumption and inconsistent use of pancreatic enzymes. She has a history of multiple emergency department visits and hospitalizations for respiratory infections. Documentation frequently notes, quote, non-compliance with treatment, limited engagement in follow-up care. The care plan emphasizes medication adherence, nutrition counseling, and close monitoring to prevent further complications. So we felt like there were several things that we would change, but there were some things that we thought we could leave the same, and one of those was just the first sentence. Our group talked about why the first sentence would maybe still be a helpful one to have, and that was because noting that we were taking care of a Hispanic female was important to us, because it's the identity of the individual, and there are cultural differences that a Hispanic female might have, as well as noting in the CF population that they have limited access to ETI or modulators or genetic mutations that would qualify for those modulators. We talked about whether we would change wording for worsening lung function and frequent pulmonary exacerbations, but we didn't feel that that was too negative of language that defines the concern that she's presenting with. But then we said that we would change some of the following. So we rewrote it to, she reports difficulty affording her medications and airway clearance equipment. And then we kind of stopped there and said that that was factual. But then moved along to, due to transportation barriers, she expressed that she had missed her last several appointments, kind of putting it on her, saying that like she's explaining why she missed her appointments. And then we felt like we didn't need to focus on her unemployment or, but instead we said she has 3 children, is currently not employed, and does have public assistance in place. And then moving on beyond that, we didn't like the following sentence about her nutrition and the way it was described about her fast food. So we put providers currently have concerns about her nutrition, and she reports inconsistent use of her pancreatic enzymes. Then I think we kind of went out of time. So I just started to try to write, but she has needed to visit the ED and has been hospitalized for respiratory infections, which is a factual statement. And we really wanted to change the last sentence for the care plan to be about the individual. So I put the care plan focuses on barriers to access to care, healthy food options, and close monitoring to decrease further exacerbations and further decline in her lung function.
Thank you.
Thank you.
So we want to take some time to just kind of debrief these activities that we've done or engaged in today, thinking about the individual activities that we began with, and then thinking about the group activities that we have worked through. Just again, definitely, we don't have to have the mic unless you're, okay, all right, he's back at running the mic for us. But when we think about these activities and we think about them in the context of equity, and we think about it in the context of respecting and honoring humanity and the lived experience, what do you feel like overall you feel like you've walked away with? Or what do you feel like these activities really represent when it comes to us as clinicians?
I would say, I think that I found that it's a mind shift, but you can say the important things in a respectful way. And so really pulling out the things that are not useful or helpful and not focused on what the patient identifies as a goal, or not focused on, you know, what has been a challenge or what's a big concern from the medical team. So just training ourselves and getting better at saying what is actually needed for the family and patient, and doing it with respect, and like they're making those decisions, or these are important beliefs to them, you know, really using what they've shared with us, which means we need to have trustful relationships and build rapport and stuff.
Thank you for sharing. What else?
One of the big takeaways is that instead of these people having something, they're experiencing it. They may be experiencing it or experiencing it. It's not that it takes away the label and turns it into a situation.
Mm-hmm. All right.
I think it's also just taking the time to be mindful and think about what you're writing. I noticed in our ethics presentation this morning, there was a lot of talk about like what you do when a family refuses treatment. And at the time I felt uncomfortable with the word refuses, but I suspect the presenter was just, kind of rushed and, didn't mean it to be a judgmental or harsh word. But you really kind of do have to take the time to think about those things.
So this part, like the thinking about it like maybe introspectively, I think the easiest thing to do is to pretend like you're writing the note about your friend or your family member. So like if this was my friend, how would I want it to read? Because you're extra mindful when you think it's somebody that's gonna see it. Or like say like if your coworker is admitted and you're doing the discharge planning, right? Like you want to make sure, oh, they're going to see this note. I need to make sure I write it this way, but we should technically be doing that for everyone. Like somebody refers to all of her patients as friends, but like if we really did type it that way, like I think it would change how we are writing it. But I honestly feel like that conversation needs to go beyond the psychosocial professionals. And I know there are some other people in this room, but I can think of a lot of different disciplines on my team who need to be in this talk.
Please invite, please share.
Thank you. And I will say Chandra and I were having that conversation while you all were working.
One of the things too, I want to pause here for a second because Susanna touched on something really important. And the reason we did the activity in the beginning of really trying to orient us to this work is because it is not business, it's personal. When we think about writing about the lived experience, we're hired in our individual disciplines, but it's still the humanity that we bring first to anything that we do. So when we are intentional about pausing, if we look back at our list or our circle or who's in our circle, think about those people. Think about that could be my neighbor. That could be my mother. That could be. Because the reality is that we are all a patient at some point in time, or we're all interacting with another system of care or whatever it might be. We're navigating life, right? And who we show up with outwardly is not truly who we are and who we walk into that encounter as being. And when we think about healthcare, people are coming to us with the most precious thing that they have, which is life. In what way can we honor being given the privilege that they're coming to us with a life matter? And if we diminish and demise, or we continue to perpetuate stereotypes and we continue to perpetuate bias, it doesn't help, it harms. And the reality is that too, words have cultural context. My view of unsafe and your view of unsafe can be totally different depending on where I start. My view of housing instability looks different from someone else's housing instability based on where you start. So it's not about where our patients are coming from. We want to understand that, but we want to understand how we can help make the lived experience just that much more manageable in the moments that we have with them. We may not be able to give all the answers. We may not be able to cure everything, change everything that they come with, but in those moments, if it's a matter of a conversation or even in the matter of writing, how do we write a love note that reflects who they are through our writing? So as we begin to wrap up today, I really want us to think about how we can incorporate. It's not about a professional role in this conversation. So remember earlier I said, come on, we're going to have a real conversation today. And yes, we're here with our professional hats, but we wanted you to be here showing up as yourself. Not showing up as that nurse practitioner because this is what I have to do, but showing up as yourself as a person who is in the healthcare community because you care. But we can show care not only with the words, not only the physical things that we do because of our discipline, but we can also show care in the words that we choose to use. And that means stopping, pausing, and thinking, as Susanna said. She took the last of our slides, so I'm really not going to have to put them there, but really taking the time to really stop. So what we're asking is you to think about, what is one thing you're willing to intentionally commit to do differently moving forward in your writing? And I want you to think about that because it takes being intentional. Many times we can say we go to conferences, workshops, we get a lot of information. Oh, that is so great. NACFC is one of those things. We come back with a lot of ideas and we get back to our normal. Sometimes those notes or all those things or handouts that we got collect dust. We don't remember the content. But if there's one thing that we're asking you to this year's NACFC, is commit to honoring and respecting the diversity of the lived experience. And we can do that through the words we choose to say and the words we choose to write. So we're going to ask you to write it down. What are you committing to do? We're going to ask you to claim it. and then we're going to ask you to carry it with you. Because equity is not about one person doing all the work. It's a collective effort. And if we're all being intentional about the things that we do and the things that we say, then we can honor and respect differences. Because what you did in the beginning of this exercise wasn't about me, it wasn't about Abe, and it wasn't about your neighbor. You were able to identify life experiences that have touched you personally one-on-one that may be uncomfortable, but you also were able to identify life's issues that touch people that you love that haven't been uncomfortable. So when we think about writing, when we think about speaking, when we think about engaging, realizing that the personal really does come first before the professional. And when we keep that intentionality, we can be purposeful in the ways that we create stories for our patients, for that next provider. So our takeaways are simple. Equity in writing is not abstract. It's about real people, often people we already love and know. That labels reduce, but context restores. Choose language that names barriers and honors strengths and not deficits. And that dignity travels through our words. What you write can outlast the moment and will follow a person across systems of care. And last but not least, equity begins with a pause. Before writing, ask, would this language honor my loved one if it were about them? So with that, we want to just share some resources that are available in our presentation, and the presentation is available in the app. But also we want to say thank you. And we want to acknowledge the CF Foundation for allowing us to create this workshop. We want to thank you, Cindy George, for giving us this platform. Thank you for our patients who require us to show up every day giving our best. So we want to just say thank you for joining us.
Thank you. And then just, this is a last minute add-on real quick before people leave, if they have interest, and I presume everyone does, we have a huge amount of swag for the Pride CF study over here that we encourage folks to take, hang posters in their clinics. We're trying to recruit folks to this study. Thank you.
And just another plug as well, thinking about equity and diversity, inclusion, we have the Infinity groups, we have the LGBTQ, the Hispanic community, as well as the Black CF professionals in CF 6:30 tomorrow after the plenary.